Good morning, everyone. We'll go ahead and get started this morning. We're very excited to have Dr. Apoorva Ram here with us this morning to talk about updates in contraception. Dr. Ram's a primary care physician at the Anschutz Internal Medicine Clinic, the clinical content director for healthcare structures, policy, and economics here in the medical school, and is also affiliate faculty at the Eugene S. Farley Jr. Health Policy Center. Dr. Ram did undergrad at WashU St. Louis Medical School at Northwestern in Chicago, internal medicine residency here at the University of Colorado, followed by chief residency, and then joined us here with at the faculty. In terms of today's talk, if you have questions and you're attending via Zoom, please, as always, put them in the chat. I will be monitoring that and asking those questions. For our audience in person, if you have a question, please raise your hand. I'll be circulating with the microphone so everyone can hear that question. And with that, I'll turn it over to Dr. Ram.
Thank you so much for that introduction. One other thing I'll add is for the folks that are here in person, we have Zoom questions. And so if you're able to log into the Zoom on your phone, you can answer the questions in there if you want. All right, so I want to start this talk by just saying that I am certainly no expert in any of this. Most of my background in this specific topic kind of comes from some training I did in family planning clinics through the Denver Health Primary Care track here. And then obviously just sort of independent reading, conferences, things like that. But my hope is that this is very much sort of like a primary care person's perspective on contraception and not sort of an OBGYN or like a family planning specific one. Please feel free to ask questions throughout. I just want this to be helpful for you all. All right. There we go. A couple disclosures. I have no financial disclosures. And then I do use the term woman or woman as some of the data and studies are not inclusive of non-binary people, but when possible, I'll try to use the term people. Okay, so our learning objectives. I want to end this talk with you all feeling like you have a structured approach to contraceptive counseling. I want to focus a little bit on fertility awareness-based methods. Just anecdotally, these have been rising in popularity. So I think it'll be good for us to be sort of prepared to talk about this with patients, outlining sort of safe use of emergency contraception and best practices. And then the last piece will be sort of integrating your framework for contraceptive counseling with special considerations for people in their later reproductive years. So I'm going to start with a kind of a fun question, but we're going to follow this case of Jamila, who is a 38-year-old cis woman who's in your primary care practice. She comes in with the chief concern, IUD removal, secondary to side effects. Your MA notes that she doesn't know which IUD that they have. Can you tell which IUD it is? This is a Zoom poll. Dr. Foos, do you know if I have to answer it to see the answers?
You do not need to answer it, but I have them on my screen, so I can tell you in a moment.
Great.
All right. We have 47% of people saying yes by string color, 12% saying yes by side effect profile, 41% saying not until you take it out, and 0% saying no, they are all identical.
Great. Okay. Do I exit that? Oh, great. You're on it. Okay. Yeah, good job, everybody. So side effect profiles definitely can be really helpful, but they're also not definitive. And so the easiest way to tell the difference is actually by string color. So if you have a patient who's like, I have no idea which one I have placed, and you're doing a pelvic exam, if it has a white string, then you know that it's pretty much the copper IUD. And then if it's a colored string, it's one of the hormonals. I find it kind of hard to tell the difference between brown and blue with a lot of other sort of like secretions and things like that. But at least you can tell whether it's hormonal or copper. Okay, so coming back to Jamila's case, so she has a levonorgestrel IUD, and she does say that she wants another method, but she hasn't really had time to research all of the options. And so, that's weird. And so, as we are kind of considering the counseling piece, I just want to put one brief kind of reminder of sort of our legacy in medicine. And so, there is a not so historical kind of integration of eugenics with reproductive health care. And so, you may have heard of the Mississippi appendectomy, which is basically women who were told that they were getting an appendectomy, but really were getting tubal ligations. And then there's actually even been unwanted sterilizations in prisons as late as the early 2000s, which, when I was doing some of the research for this presentation, was really shocking to me, and I think is good to keep in mind. And so the way I kind of think of this is like our job is sort of to find a method that's aligned with a person's goals and their right to bodily autonomy, recognizing that we sort of have some predetermined kind of prejudices or biases in how we think of this type of care, and people are coming to these visits with some ideas of what you might be pushing on them as well. So with that kind of framing, I think one way of counseling, and there are so many different ways, and so if there's another way that kind of works better for you that you have been using, I'd love to hear about it too. But the one that I've been taught and the one that I use is called the PATH. And so this is parenting attitude, timing, and then how important. So if we break this down a little bit, parenting attitude basically starts to open up the questions with your patient. And so you say, do you think that you would like to have children at some point? Or if you know that they already have children because you're their primary care, then you say, do you think you might like to have more children at some point? This is actually like a decision aid that you might use in like a very specific dedicated clinic, but this is basically something that you can just ask off the cuff as well. The second question, if they say yes, is what is the timing of that? So if somebody wants to have a pregnancy in 3 years, you might recommend different contraceptive methods than somebody who wants to have a pregnancy in like 12 or 15 years. And then the last question I think is really helpful to kind of get to this like sort of bodily autonomy piece that I was talking about, which is how important is it to you to prevent pregnancy until then? And I think I really like that question because I think that it really helps to get at this idea that like we as providers think of these different birth control methods as sort of like efficacy based only. And so we sort of think of like, okay, the LARCs are the most effective, and then kind of going all the way down to maybe barrier methods or something like that. But that's not always actually what patients care about the most. And so kind of getting a sense of where they're at on that, how effective they want this to be, spectrum is really helpful for me. I will note that this PATH contraception counseling method does not include screening for medical conditions. And so I'll talk about that a little bit more and how I do that. And it also does not talk about symptoms. And so I created a dot phrase for this with a slightly modified one that includes symptom profiles that might be affected by different contraceptive methods. So for example, acne, hirsutism, menstrual migraines, painful bleeding, all of those things might be better addressed with certain types of contraception than others. And then I forgot to say at the beginning of this talk, but whenever there's this little emoji picture in the bottom left corner, I made a dot phrase for that. Although I guess now with ambient, dot phrases are less necessary. But if you want to steal them, I think I sent them out to Sarah so she can email them out at the end. Okay, the next question. So updates on duration of use. So select the answer choice that correctly reports the FDA approved duration in years for each method.
So rather than read every letter and number, I'm going to go A, B, C, and D.
Sounds good.
For choice A, 9% of the audience selected that. Choice B, 5%. Choice C, 36%. And choice D, 50%.
Okay, great. I like it when we have a spread because that means that I have something to teach. Okay, so going to our answer choice. So the people who picked C and D are definitely on sort of that right track of like where our most recent data is, but it's really confusing because every single time they publish new studies, the duration pretty much gets longer for all of these different things. So we kind of started out with shorter durations, and then studies have basically shown that these last a lot longer than we expect in many scenarios. The official FDA approved durations are answer choice D. So copper IUD lasts 10 years, levonorgestrel IUD, which is all of the I guess only the longest acting ones, so like we'll say Mirena and Liletta, last 8 years. Obviously, Kylena and Skyla are smaller, and so they last less time. And then the implant is technically only FDA approved for 3 years. But Answer Choice C actually has the durations that have been approved sort of by studies and are recommended by certain guidelines, but are technically not FDA level approvals. And so I think the biggest difference here to me is the implant. So a lot of people would prefer to have the implant for 5 years if they're not having abnormal bleeding or something like that in those last year 4 and 5, and prefer to just leave that in. And then same with the copper IUD. Plenty of people will decide to leave that in if you sort of talk to them about, it's not technically FDA approved, but there are some studies that show that this is effective until this time. Okay. So this is one of the resources that I really like to use for patients. So it's called bedsider.org. And essentially going across the top, you have all of these different filters. And so if a patient says, my priority is really that it be hormone free, I've had really bad side effects with hormones, you can click on this and it'll just filter out all of the options that have hormones in them. Talking about some of the new methods, you've probably heard about the O pill. It's not super new. It's been available since spring of 2024. It is the over-the-counter progestin-only pill. I will say awareness of this is pretty low. And in some studies that I read, it's pretty skewed towards white women in particular, as opposed to kind of the general population. And so this is something just to make people aware of. There are so few contraindications to progestin-only pills that's why they decided to make it available over the counter. Another semi-new one is called Phexxi. And so this is a prescription-only vaginal gel. It's not a spermicide. It's more of a stun gun. It kind of stops the sperm in their tracks from actually fertilizing an egg. It's made up of, I think, a bunch of different types of acids. And if you use it with a barrier method, it is much more effective. And it is more effective than an over-the-counter spermicide. And so this can be a good option for people who sort of want something that's not hormonal, want something that they can use with a barrier method, but don't want to buy over-the-counter spermicide because it's not as effective. I've actually had a couple of people use this. One person got pregnant, the rest have not. So yeah, she was okay with it. Next is the Anovera, which is essentially NuvaRing's like year-long cousin. And so the way this works is you put the ring in for 3 weeks, you take the ring out, you wash it, you wait a week, and then you repeat. So you keep putting it back. And you use this for 13 cycles. And so if y'all have never seen a NuvaRing, it looks a lot like this, but is clear. And so this is the Anovera, which is the year-long version. Insurance, as far as I know, is covering it pretty well. Maybe wish providers can let me know too if they have been experiencing something different, but I don't have a ton of people on this. Usually they want the NuvaRing. Okay, so summarizing some resources and counseling options. This slide has a lot, so I'm going to start on this side. This is the Contraception point of care app. And I think it's a little bit concerning to me that this one sperm is outside of the X, but I guess that is consistent with how some contraception works. But basically, this is a updated source that takes into account not just CDC guidelines, but also other studies. Someone is updating this kind of pretty consistently over time. And I have this on my phone and I'll pull it up to both look at medical eligibility. So for example, if someone has some kind of medical condition that I can't remember if that has a contraindication to combined hormonal contraception, I can pull up a chart and we'll kind of go through that a little bit later too. They have both a Google version and an Apple version. And then the other one, which is the more sort of official one, is the CDC medical eligibility criteria app. I think there was some concern that this was not getting updated in the last year or so. And so I have switched over to mostly using this contraception point of care app because I want the most updated information. Yeah.
When you're done with the slide, can you go back one?
Yes. The last big resource on this is the UCSF My Birth Control Aid. So this is a very, very long interactive tool that people can use online. And so I don't recommend that you necessarily pull this up during your visit and kind of go through it. But sometimes this can be helpful if someone says hey, I'm thinking about a birth control option. I have no idea what I really want. I'll just pull it up on the screen when I'm leaving the room. And then they'll kind of be able to click through it, get a bunch more information about what the different birth control options are that they can kind of use to sort of help guide their own choices. And then Steve, I actually don't know that I know how to go back. Oh, I think I figured it out.
So with the and please correct my pronunciation, but the aloe vera. The instructions there say leave it in for 3 weeks, take it out, remove for 1 week, repeat. Is it possible to use it continuously,
Yeah.
or does it have to have that 1 week out?
No, you can use it continuously, just like the Nuva ring.
What is the benefit that removing for 1 week?
Sorry, what's that?
What's the benefit to removing for 1 week?
So I think it's a personal preference thing in my experience most of the time. So some people prefer to get a period, some people don't. I think if you're using it for something like menstrual migraine, or if you're using it for something like PCOS, you might opt for a more continuous regimen so that there's no drop in estrogen. But if someone is using it just for birth control, I think they kind of have the option to decide which one they want to do. Great. Okay, so this is a essentially like a flow chart that I took a picture of and put into Epic of how to actually pick a combined hormonal contraception, because it feels like there is a million and one choices every time you go into your Epic ordering piece. And so I basically combined a whole bunch of different articles and guidelines on how to choose this for people, and then tried to convert it into a picture form. So the way I've separated this out is you start with the estrogen component, right? Combined hormonal contraceptions have an estrogen component and a progesterone component. If you decide that they need a low estrogen component for whatever reason, so that's on this side, like let's say they have some kind of higher risk of ASCVD, but not so high that estrogen is completely contraindicated. Let's say that they have a family history of blood clot, but they themselves have never had a blood clot. And for whatever reason, they themselves just wish to minimize hormones. So you kind of start with the lower dose estradiol. So usually that's either 10, 15, or 20 is what we sort of consider low dose. If they have nothing that requires them to have a low estrogen and you want to minimize unscheduled bleeding, then you can potentially start with the 30 to 35. And this is, again, just kind of like a summation of a lot of different guidelines. This is by no means the only way to pick how you start combined hormonal contraceptives. The next kind of decision point is sort of, do you want to try to minimize androgenic effects or minimize VTE risk? And I'm going to say there's a huge caveat here. We'll go over like what the absolute VTE risk is for birth control in general. But if you're trying to sort of minimize androgenic effects, theoretically, you would want to pick a third or fourth generation progesterone. But because you're in this side of the bucket where someone maybe has a family history of VTE, I've kind of put in here that you pick like a first generation or second generation progesterone, even though those might cause a little bit more androgenicity. If you're trying to minimize VTE risk as much as possible, then you definitely want to pick a first or second generation progesterone. And so I'll kind of show you on the next slide a table of all of the different generations of progesterone so that this kind of makes sense. I think that this flowchart goes really well with the next one. And then on the other side of the spectrum, like if you are sort of saying, I want to minimize unscheduled bleeding, there is no reason to minimize estrogen, you kind of have those same options. But this time in the minimizing androgenic effects, you do kind of have the option to pick a third or fourth generation progesterone. So that would be drospirenone, desogestrel. I do not know how to pronounce these, nor gestimate. And so on the bottom, across the bottom, I've put some of the most common types of combined hormonal contraceptives. What I would recommend is look at this chart maybe like once and then save one or two of these options from each bucket and then just use those forever. I will also say that when someone is coming to you on birth control and they like their birth control, I often will just leave them on their birth control. So this is what I do when I am starting someone anew on it. Okay, so going into the progesterones. I've been talking about what the heck are first generation, second generation, fourth generation. So basically, progesterones have these 4 different generations. And when you start at the first generation, and they go all the way up to the 4th generation. And they're called these because of when they were invented, I believe. And so when you start with the 1st or 2nd generation, those are slightly more androgenic. And then the 3rd and 4th generations have a slightly higher risk of VTE. But I will say, and this is where the huge caveat is, the absolute risk of drospirenone containing combined oral contraceptives is only 10 to 15 venous thromboembolisms per 10,000 women per year. And so comparing that to the number of people who use levonorgestrel, it's really only an increase of maybe 2 to 7 more women per 10,000 women years. And if you compare that to the risk in pregnancy, the risk in pregnancy is hugely variable, but it can be as high as 20. And so when you're thinking like, do I want to put somebody on something that's like such a high risk of blood clots? It's not actually that much higher of a risk of blood clots than getting pregnant. And so it's important, I think, to like sort of situate that risk within the risk of pregnancy and within the risk of other birth control as well. Okay. This is also on my dot phrases. Okay, so a couple pearls just to wrap up the counseling section. I love the Contraception Point of Care app. I recommend it. In there, there's also these one-page guides on quick start methods. So this is a change, I would say, in the last like, I don't know, 10-ish years or so, I've heard, which is essentially that we can pretty much start almost any birth control option same day. There's obviously some caveats there, and you want to have a negative pregnancy test, and you want to be sort of reasonably sure that somebody isn't pregnant. And then when you're counseling, it's kind of switched over to say that we should potentially be actually counseling more by pregnancy rate. So saying like 1 in 100 people will get pregnant with this method, as opposed to doing efficacy of saying like this is 85% efficacious to prevent pregnancy. And talking about efficacy, we also want to avoid counseling based only on that if that's like not really the person's priority, kind of going back to our intrinsic bias of we think long-acting reversible contraception is so great. And then avoiding pregnancy is not the only goal. So just keep that in mind when you're thinking. And then best practice is actually to prescribe a year's worth at a time. So either 365 tablets or 90 days with 4 refills. Sometimes when I try to prescribe 365 days, insurance will make me do 90 days with 4 refills. But this is technically recommended. Obviously, you would have the clinical sort of clinical decision-making where if someone that you think is maybe higher risk, you would maybe want to do more frequent check-ins, things like that. But in an uncomplicated person, it's recommended to do a year's worth at a time. Okay, so Jamila comes back to see you after looking through all of this counseling stuff, going home, reading on Bedsider, and she says she's kind of interested in pregnancy in the next 1 to 2 years. But after going through bedsider.org, she decides that she wants to explore fertility awareness-based methods, or FABMs. How do those work? I guess for the people in the room, since it's kind of small, I can read them out. So answer choice A is they don't. They have the same pregnancy rate as not using a method. B, they all involve tracking bodily signs and symptoms. C, they are all proprietary apps. D, they all rely on intuition.
And for results, we had 4% saying they don't, 96% saying they all involve tracking bodily signs and symptoms, and then 0% for their proprietary apps and 0% for relying on intuition.
Great. Can people who put they rely on bodily signs and symptoms put in the chat or say out loud what signs and symptoms those are? That's the right answer. Yeah, so they all basically rely on understanding female physiology and what the fertile window is, and then potentially avoiding pregnancy or using a barrier method or some other form of contraception during that fertile window. So this is that chart that we all saw in medical school, but now plus on the bottom, the different signs and bodily symptoms that we use in fertility awareness-based methods. So starting at the top, pituitary hormones, they are kind of stable. They both spike. And then that's what causes ovulation. If the egg is not fertilized, it becomes the corpus luteum, which degenerates, and then you get your period. What essentially these methods are doing are tracking the impact of these ovarian hormones on your body. So on the endometrial, not necessarily endometrial changes, the cervical changes, the cervical mucus, and then the basal body temperature. So as your estrogen is increasing prior to ovulation, you will get more and more cervical mucus that is more stretchy. So what this Distance shows is, I guess, the average stretchiness of the cervical mucus. So this is something that people check by inserting one of their fingers into their vagina and then looking at the cervical mucus kind of once it comes out. Another thing they can check is actually cervical position. And so this isn't super well demonstrated in this picture, but as you get closer to ovulation, the cervix moves up higher and I believe gets softer. I'm not 100% sure on that one. And then the last thing that people will measure is basal body temperature. So as you have the estrogen predominant as you have the estrogen as the predominant hormone in your system, your basal body temperature will be lower. It will essentially spike after ovulation when progesterone becomes the predominant hormone. And so essentially what all of these fertility awareness based methods do, FABMs, is they combine all of these different things in various configurations. So like some will be just temperature and cervical mucus. Some will be timing only, called the calendar method. And then based on that, you calculate what the fertile window is, and then you avoid intercourse if you're trying to prevent pregnancy in that window, or you use some other method like condoms. Okay, so this is a lot. So there is an interactive tool because I don't think there's a super good way, if you don't do this all the time, to be super familiar with all of these methods, right? Like there's too much to kind of keep track of. I don't know that I would even be able to counsel a person on exactly how to use this, but I want to be able to tell people in general kind of how effective or how big of a failure rate, if we're switching to the correct way of counseling, are these. And so I'm going to first go through the data on some of these, and then I'll click over to the interactive tool just to kind of show you how it works. Okay, so there was a systematic review that looked at 53 studies. None of them, unfortunately, were considered high quality, but several of them, or most of them, were moderate quality. And they basically looked at both typical and perfect use of a specific set of fertility awareness-based methods. Big caveat here, I think, is that the ones that they looked at are certainly not representative of all of the ones that are available, because there are a huge proliferation of these proprietary apps like programs, groups, and things like that that are not actually as studied. And so when they actually looked at sort of typical use, they saw that it varied between 4 and 14 pregnancies per 100 woman years. But however, when they looked at perfect use, the most effective methods were the Sensi plan and the Marquette monitor. And those actually showed perfect use of 1.8 to 2 to 6.8 pregnancies per 100 women years. So it was actually a lot more effective than I sort of initially thought looking at this. Another big caveat here in the article that they talk about a lot is that this is really a very specific population who's been studied, right? So the population that are in these studies tends to be people who have a very, very high interest in following all these bodily signs and symptoms, high health literacy, kind of things like that. So like, is this really generalizable to a larger population? We don't know, because unfortunately the data is not as perfect as I think we would all want it to be. Okay, questions about fertility. Oh man. I showed you the answer. But I wanted to pause and see if there were questions about fertility awareness-based methods, because I think that might be the newest piece for people in this talk. Oh God, I don't think I can. I would have to look at it a little here. What we can do is we can, this is a good question for the, okay. This is a good question for the interactive tool. Okay. So hopefully y'all can see this interactive tool. So if we are curious about the Marquette monitor, we basically click on it and it gives us a bunch of information. And so it says estimated failure rate. It has who the prediction is made by. So it looks like in this case, the Marquette monitor is some kind of algorithm that it uses. And then the biomarkers that are used in the Marquette method monitor is the menstrual cycle, cervical mucus, it looks like, is optional, and then they use urinary hormones. So that would probably be like a luteinizing hormone strip or something like that. I will say a lot of these fertility awareness-based methods have certain requirements. And so in general, you have to have really regular cycles, right? Someone with PCOS who's like varying their cycles from like 20 days to like 40 days, it's going to be really hard to use one of these methods because your ovulation is going to be very unpredictable. And so that's another thing to kind of know. Another thing that I think is really interesting is that a lot of these actually grew out of religious kind of religious like versions of family planning. And so some of them have a religious component. The Marquette Monitor and Sensi Plan are actually two of the ones that have religious components. What I think I remember about the Marquette Monitor is that it is like a physical monitor that you put the ovulation strips and stuff into. Yeah, it looks like we have another question.
Yeah.
Oh,
no, I'm looking at certified teacher required. What
yeah.
What does that look like?
Yeah, exactly. So basically, I actually looked into this when I was writing this talk. And yeah, so some of them require certified teachers. And so that is one way in which you like have more, right, like more standardization between the way people are doing it. But it also makes it a much higher bar for people to actually get this method. And so there are also sort of like off-label versions without certified teachers that you can get for all of these things too. But yeah, but technically you need a certified teacher to officially teach you that method, which I think is another reason why perfect use is probably so high, right? For that method is because they have a very strict way of sort of teaching it and helping people use it. Another one that I'll show is like natural cycle. So this is a very different type of process. And so this is essentially an app. It also uses an algorithm. It mostly uses timing of your menstrual cycle. So calendar-based method, and then basal body temperature to calculate your fertile window. And so there's a big range, right, with how well these work. The other thing I really like about this interactive tool, and then I'll stop talking about fertility awareness-based methods, is it compares down at the bottom to some of the other contraceptive methods that we might be more familiar with, right? And so if you look at withdrawal, this is potentially better / equal to withdrawal, potentially around the same as male condom, but is on average probably not quite as effective at preventing pregnancy as a combined birth control pill. So that's kind of where I might put it in the schema that we already all have in our mind. Yeah.
If a patient selects a method which is using the basal body temperature, what's the implication if they get an infection and have a fever from that?
Yeah, good question. So my understanding is that you disregard temperatures that are affected by things like, let's say, shift in night. What am I trying to say? Shift work. So if someone works nights, like this is not going to be a super good method for them. If somebody gets a fever, like they're not going to be able to as accurately predict their fertile window in that time frame. And so that's why a lot of these involve so much learning and like health literacy, because you have to be able to incorporate all of these like other things that come into play, whereas a birth control pill is going to work whether you have a fever or not. Good questions. Okay. I think I already showed you the answer to this one, unfortunately, but we can, here's the full screen, there it is. But we can still go through the process. So Jamila makes a follow-up visit because she had unprotected sex in the fertile window 2 days ago. She took Plan B last month for the same scenario because she finds that if she has sex during that window, she gets really nervous. She feels like the FABM isn't really working for her, so she asks about using Plan B again. What options for emergency contraception does she have? Hopefully not everybody saw the answer that I accidentally showed. Your options are copper IUD, Plan B, and Ella. Both types of IUDs, so copper and progesterone IUD, Plan B and Ella, just Plan B and Ella, or copper IUD. Are we getting any answers?
We sure are getting answers. So we have 27% of people selecting choice A, and then 73% the remainder selecting choice B.
Okay, great. Yeah. So technically, they're all options: copper IUD, hormonal IUD, Plan B, and Ella. But the levonorgestrel IUD is not quite as mainstream as the copper IUD yet. And I don't think, I have to remember exactly, so hopefully someone can correct me if I'm wrong. I don't think it's technically FDA approved, but there is a very good study that I read showing that levonorgestrel IUD works just as well as copper IUD. Okay, so Another flow chart. I guess I was obsessed with making flow charts when I made this talk. So emergency contraception. If we start on sort of the wants an IUD option and they are in the correct window, which for IUD is within 5 days of the unprotected intercourse that is the concerning intercourse, then you can just go ahead and place the copper or hormonal IUD, and you want to repeat your urine pregnancy test around 2 to 3 weeks after. If they are not within 5 days of intercourse, you might want to consider doing oral emergency contraception. We'll talk a little bit about that. It is less effective when it's not in that 5-day window, but it's still better than no emergency contraception at all, we think. If, let's say, they have no timely access or they just want an oral option, they don't want an IUD for long-term birth control, the first kind of delineating factor is whether or not this is within 3 days of intercourse. If it is within 3 days of intercourse, Plan B and Ella are both eligible for you to use. If it's after 3 days and it's specifically approved for between 3 and 5 days, then Ella is technically preferred over Plan B. That being said, even though it's technically only approved up to 5 days, we think there's potentially effect longer than that too. So if someone's outside that window, it's not like you can't give them Ella. It's just good to counsel them that it might not be as effective. A couple other considerations, which I thought was really interesting. The IUD actually has a much lower pregnancy rate than the oral emergency contraception. And I think one anecdotal thing that I've noticed with patients is that people really think that if they take Plan B or Ella, they 100% will not get pregnant, which is not true. And so it's super important when we prescribe this medication to people to sort of say, like, this is not 100% effective. So even if you take it, you need to take another pregnancy test to make sure that you're not pregnant in 2 weeks or whatever it might be. One of the other pieces to know is BMI, unfortunately, was one of the things that they have not studied super well in emergency contraception, in my opinion. And so for now, Ella is preferred for people with a BMI greater than 30, but it's not a complete contraindication to using Plan B or something like that. And then another really important thing to know about Ella is that it can only be used once per cycle. And after you use Ella, you have to hold other forms of contraception for 5 days that contain progesterone. Is there a question?
Yeah. How far outside of this 3 to 5 day window
are we talking?
Did the study actually look at?
Oh God, I read the study now a long time ago. So if anybody else in the chat knows or here knows, please feel free to jump in. But I think it was like basically like after the unprotected sex and before the expected period. But I'm not 100% sure. It's not like, months later kind of thing. Yeah. Yeah. I don't remember the exact window, but it's not that far. Yeah. Good question. Any other questions in the chat or anything in the room? Okay. Great. So emergency contraception pearls. Oh yeah, I should say this in the last slide too, but one of the other things is it's actually recommended to prescribe this ahead of time if that's in patient's goal. So like say they are not really feeling like they want to be on a long-term birth control method, but they're worried they might have like one-time thing happen in the future. You can actually just prescribe this ahead of time so that they have like pill in pocket and they don't have to contact you to get it, or they don't have to go into a pharmacy to get it. Effectiveness, IUD is more effective than Ella, which is more effective than Plan B. If you're using Ella, just remember that you have to restart the hormonal birth control, like a combined oral contraceptive, after 5 days. And then emergency contraception is not considered abortion, and it is not restricted in current policies in Colorado. So this is still accessible to all of us right now. I checked this morning. Next question. Jamila opts for the copper IUD, and she has it for 10 years. She then turns 47. You're still her primary care doctor, and she starts to develop perimenopause. I'm not going to go into that because I think that's a whole other talk that I would love to hear. She has migraine with aura, hypertension, and coronary artery disease. She does not want to get pregnant, and so she asks about options for birth control. What limitations would she have now due to age and comorbidities? So our options are none. She can choose any birth control option. A combined oral contraceptive is contraindicated with her comorbidities. It doesn't matter. She no longer needs birth control as she is in perimenopause.
So answers are rolling in, but they are coming in more slowly than the other questions. And so I think there may be some hesitancy or uncertainty here from the audience. And 20% of people said none. She can choose any birth control option. And then the remaining 80% chose a combined oral contraceptive is contraindicated with her comorbidities.
Okay. Great. I like it when there's confusion. I also hope someone's using the app. That would be great. Okay. So I think technically for her, with her combination of all of her comorbidities, I would say that a combined oral contraceptive is not indicated for her with her comorbidities. But I do think it's up for a debate. So this is a picture of that app that I was telling you about, that contraception point of care app. So I've highlighted here specifically Jamila's comorbidities, right? So she has headache, migraine with aura, which puts her in this bucket of number 4 risk. And basically that goes from 1, 2, 3, 4, right? Green and yellow, which are 1 and 2, are ones that I'll say, okay, that's okay. 2, I'll like talk about the risks and benefits. 3 and 4, I'll kind of say, maybe we should consider a different option, a little bit more strongly counseling about the risks. The other comorbidities that she has is hypertension. I think this is a really good one for us to talk about since so many of our patients have hypertension. So if they have a history of hypertension during pregnancy, that's actually a very slight increased risk for adverse effects, but not enough that I would say like you should definitely not be on it. And if they have adequately controlled hypertension, it's technically a 3, but I do know a lot of providers, myself included, who will still prescribe combined hormonal contraception in someone who has mild hypertension that is very well controlled. And the risk essentially goes up the more uncontrolled your hypertension is, or if you have associated vascular disease, which I actually really like that they put that in the hypertension bucket and they don't make it a separate part of the MEC, medical eligibility criteria chart. The other one is ischemic heart disease. And so ischemic heart disease, so having a history of this or current ischemic heart disease, is a pretty strong contraindication to estrogen-containing methods. So for her, I would say we would probably recommend against combined hormonal contraception and potentially the progesterone injections, which I thought was interesting. And that is mostly because of the impact on hypertension. So it would depend on sort of how well controlled her hypertension is, what type of ischemic heart disease she had. But interestingly, the progesterone injection also seems to have a higher risk in people with ischemic heart disease as well. Okay. So a word on migraine with aura in combined hormonal contraception. So first, an aura has very, very specific criteria. So a lot of people think that they have auras when really they don't, and then feel like they can't be on the combined hormonal contraception. So that's the first piece, is it's super important to accurately diagnose aura. So I just put that definition up here. I won't read through it. I have to look this up every single time that I'm trying to diagnose someone with new aura. But I think this is the most important and interesting piece. So there was a really interesting article that basically looked at what is the true risk of migraine with aura and using combined hormonal contraception. So what they first looked at is in this top chart. And you can see here the estradiol level over time during someone's menstrual cycle. And so it starts out low, it goes up, 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 and then it kind of peaks right around ovulation. And that is actually when aura is the most common in somebody's cycle. Then it kind of starts dropping. And then when you have estrogen withdrawal is sort of when we think of menstrual related migraines in most people, although there's kind of some complicated definitions there. If we are thinking about a typical combined hormonal contraceptive dose that you're using for 3 weeks, and then you're on the placebo, this red line is the 30 to 35 microgram dose, right? So that's what we would consider a higher dose estrogen in our current formulations of combined hormonal contraception. So that is actually right around the peak and essentially exposes people to that peak level of estrogen throughout their cycle. But if you look at this green line, that is the low dose continuous regimen. And that is actually a lower estrogen risk throughout their cycle compared to what they would be doing if they were naturally cycling. And so what this article basically looked at is like, what is the actual dose of estrogen? And does that matter for your stroke risk when you have migraine with aura? And another really important thing to note is that a lot of the initial studies, like in the 1970s and a little bit after that, were looking at really high dose estrogen. So 50 micrograms, which is not really what we use in combined hormonal contraception anymore. They've also changed the type of estrogen to, I think, like a more synthetic form. It's lost on me for pharmacokinetics and stuff. But essentially, the type of estrogen has changed and the dose has changed over time. And so if you actually look at how does estrogen dose and estrogen serum levels correspond with aura and therefore with stroke risk, you basically see that the risk of stroke increases with both the frequency of aura and the estrogen content of the birth control. So if you have someone who has aura less than once a month, their risk of stroke is 2 times higher. The estrogen content with the lowest option is actually around that same risk. So it is a little bit higher than the general population, but not so much higher as I think we originally thought. This is very controversial. And so I'm not necessarily saying like prescribe these for all your patients with migraine with aura, but I think it's something that we can hopefully keep watching kind of over time and we'll get better safety data on. But in people who, let's say, have a really clear reason to be on it and have very few auras, it might be worth it to put them on these medications. Like, let's say they have endometriosis and they've had one aura in their life. That might not be a reason not to prescribe a combined hormonal contraception option for them. Okay. The last piece is, what about answer choice C? It doesn't matter. She no longer needs birth control as she's in perimenopause. Nobody fell for this trick. So when should we stop contraception? In general, you can go up until 25 years. No, 55 years. Because at 55 years, 95% of women will no longer have pregnancies, which honestly, to me, like if I were taking that odds, I would be like, I think that 5% risk is maybe too high. So I would keep going. So I always like to say 95% of people to patients. Am I overly conservative? Maybe. Another way that you can diagnose menopause is 1 year of amenorrhea for people who are above 50, but it actually has to be 2 years of amenorrhea for people who are below 50, which I did not know. And then amenorrhea in somebody who's using hormonal contraception can't be used, right? So like if someone has the IUD, the levonorgestrel IUD, and they're amenorrheic, it's probably because of the IUD and not because they are in menopause. And then FSH cannot be reliably used. This is, again, like a whole nother conversation about menopause, but especially if you are on combined hormonal contraception. Okay. I'm not going to go over this. This is more of like a resource for you all, but essentially my main takeaway from this chart is that we think of all of these side effects of all of these different methods as being potentially harmful to people as they get older. But I think the reality is that there's very few huge risks, and a lot of the medical eligibility criteria app is more so helpful for specific medical conditions and not age alone. So age alone is not necessarily a reason to like change the way that you are prescribing your contraception and contraceptive pills specifically. And then I will say on the side here under transition to perimenopause is sort of some potential like helpful side effects essentially, right? So if someone has the levonorgestrel IUD and they're having perimenopausal changes, you can just leave that in for endometrial protection and then use an estrogen on top to help with the vasomotor symptoms or whatever that might be. Interestingly, the UK and Canada actually suggest using progestin-only methods if they're above 50, but that's not how we practice in America for combined hormonal contraception. And then the other big thing to know is that hormone replacement therapy in menopause is much lower doses than combined hormonal contraception doses. And then the other thing I'll highlight here is that emergency contraception has no restrictions based on age that we know of at this time. Okay. Ooh. So pearls on contraception in the later reproductive years. No method is completely contraindicated based on age alone, but patients are more likely to have other medical comorbidities. And so you might want to consider more frequent check-ins on safety if there's something that you're worried about, like hypertension. And then when you're considering the transition to menopausal hormone replacement therapy, there are some methods that might serve a dual purpose. So kind of thinking about that when you're transitioning at that time. Okay, these are all my dot phrases that are available. There's a couple more at the bottom. I really like the how to be reasonably sure someone is not pregnant one. I recommend that one. And then I think that's it. So I will take any other questions that are left that weren't answered during.
Back, I'd say about 4 or 5 slides, you had a heat diagram with the green, the yellow, the red.
Yeah.
And I believe one of the questions Yeah, no, I see it. When the questions from the chat was about cirrhosis and normal liver function versus impaired liver function,
Mm-hmm.
and trying to understand how we actually apply that to patients. Specifically, doesn't everyone with cirrhosis have some form of impaired liver function?
Yeah.
Is this really talking about, is their cirrhosis compensated or decompensated?
Yeah, that's kind of how I think of it. And that's how it looks on other medical eligibility criteria. Like, I think if you look at the CDC one, it specifically differentiates between compensated cirrhosis and decompensated cirrhosis. So that's how I sort of think of it. Yeah.
Question I have, you were showing us on that last slide there, the smart phrases, and
Mm-hmm.
you said you really like that one that you had in quotes, how to reasonably tell if someone is or is not pregnant.
Yeah.
Could you tell us more about that?
Yeah. So there's a really great up-to-date chart that I basically copy and pasted into this dot phrase. But essentially, our urine pregnancy tests in clinic are only effective for intercourse or only a good negative predictive value for intercourse that happened 2 weeks in the past. So if someone's coming in and they say, I had unprotected intercourse 3 weeks ago and I haven't had any since, then that negative pregnancy test is reliable to me. But if they said, I had unprotected intercourse 3 weeks ago and also yesterday, and I still haven't gotten my period, that negative pregnancy test is not necessarily going to be indicative of or is not necessarily going to have a high negative predictive value. Does that mean we can't start a birth control method? No. Like, there are certain birth control methods that you can start when there is a low risk of pregnancy. Not a low risk of pregnancy, when there is a chance of pregnancy because the hormones are so low that they would not affect an early pregnancy. But if you're putting in some kind of method, there's controversy, like for an IUD placement, that you need to be more reasonably sure that someone isn't pregnant before you put it in. Yeah, I know. Yeah. Yeah. So Rita's question is basically, if somebody said that they had sex yesterday and also 3 weeks ago and they want the IUD anyways because it's emergency contraception, then it would be indicated. But there is that window, right, where it's like they had sex 2 weeks ago and or no, you have a negative pregnancy test. So you know that they're not pregnant from any sex that happened more than 2 weeks ago, but you're not within the 5-day window. So you're between 5 days and 2 weeks of when they last had sex. And so there are actually good studies, hopefully coming out soon, that tell us whether or not we can still put in the IUD. And I think some preliminary data suggests that we can still put in the IUD for emergency contraception in that scenario. But technically, it could be an early pregnancy that would not be sort of addressed by the IUD. Yeah. It's a lot of like math and looking at calendars.
Well, Dr. Ram, thank you very much for this update. I know we all learned a lot here, and so thanks for sharing. I know at the beginning you said you're not an expert. I'd politely disagree with you there. Thank you for sharing your expertise with us on this topic.
Yeah, thank you for having me. I really appreciate it.